for this year, and we'll be hosting them as we were last year, every third week. And speaking today on behalf of the Division of Sport and Exercise Medicine is Tayla Ross, who is a graduate of our Honours Biokinetics program and was top of her class, first class pass, and also the top student voted by BASA in South Africa. So Tayla is a high flyer, and because of her nature of being such a academic, she is a member of our biokinetics staff and the Division of Sport and Exercise Medicine since June last year. And Tayla is busy completing her PhD as well, and is instrumental in setting up our cardiac rehab program for the public sector, which is what she's speaking about today. So I'm going to hand over to Tayla in a second. Before I do, if any of you would like CPD points, please put your MP numbers in an email. I'm going to put my email address in the chat bar in a second, and just email me your MP number or your HPCSA registration number. I shouldn't say MP number because some of them don't have MPs. So your HPCSA registration number, and I will ensure that you get your CPD points for the talk. And on that note, Tayla, welcome, and handing over to you.
Thank you so much. Okay. All right. I think Jeroen pretty much introduced me already, but yes, I am a bio by trade. I did my honours here at UCT in 2019, my master's in 2021, and I'm currently a PhD student. I have a particular interest actually in neurological rehabilitation, and that's the PhD focus, but my master's was focused on cardiac rehabilitation and specifically cardiac rehab within the public healthcare sector. So I thought that I would first just start chatting a little bit about what biokinetics actually is, because I've realized that very few people actually understand exactly what it is that we do. So we are healthcare professionals, and we specialize in exercise and rehabilitation. We are a recognized and registered profession with the Health Professionals Council of South Africa, and we function in alliance with other healthcare professionals. So we work very closely with OTs, physios, speech therapists, specialist physicians, and general practitioners as well. Our ultimate goal is to improve physical health status and quality of life through individualized scientific exercise prescription and assessment. And we're capable of working in very many areas. So that would include apparently healthy individuals and health promotion, rehabilitation of orthopedic injuries, neurological injury, chronic illness management, sports performance, just to name a few. So I don't think I need to dwell for too long on exactly what cardiovascular disease is, because I'm sure everyone here knows very well what it is. But it's been broadly defined as a group of disorders that affects the heart and vasculature, and it includes a number of different diseases. Typically, it evolves throughout an individual's lifespan, and it's usually asymptomatic for quite a long time, with only advanced disease leading to symptoms or even death. It's complex and multifactorial, usually develops as a complex interaction between genetic makeup and an individual's environment as well. So the global burden of cardiovascular disease is very high, and in 2015, there were 422.7 million cases reported worldwide. In 2011, cardiovascular disease was the one responsible for 1/3 of deaths worldwide. And it's predicted that cardiovascular mortality is going to continue to increase to 23.4 million by 2030. So it places a massive burden on both the individual and the healthcare system. It represents a very large financial burden on healthcare systems and on the national economy due to both direct and indirect costs, including cost of hospitalization, treatment, medication costs, professional fees, costs arising from disability, as well as a loss of productivity. At the level of the patient, so specifically those that don't succumb to the disease, there's risk of readmission into hospital, the burden of disease affecting their quality of life, their ability to return to their activities of daily living, recreational activities, as well as occupational activities. So here's just from one of the papers, it's a 2019 paper, just showing the global burden. And you can see South Africa is considered to have quite a high burden of cardiovascular disease. So in South Africa, in 2005, it was estimated that 2 to 3% of the country's gross national income and 25% of healthcare expenditure was devoted to the direct treatment of cardiovascular disease. So I know this paper is obviously quite outdated now, but I'm pretty sure it wouldn't have changed very much, possibly having even increased. And the financial burden of cardiovascular disease is particularly evident in low to middle income countries, most likely due to the scarcity of financial resources, as well as cardiovascular disease management strategies. So the high levels of morbidity and the financial burden that cardiovascular disease places strain on African healthcare systems, and these are already struggling to cope with communicable diseases such as HIV. So the economic impact comes both from direct and indirect costs, as we said, with the direct costs being to the healthcare system in terms of treatment, hospitalization, medication costs, and the indirect costs being related to decreased productivity and work loss. There's a 2004 paper called A Race Against Time, and that reported that between 5 countries, being Brazil, India, China, South Africa, and Mexico, at least 21 million future productive years were lost due to cardiovascular disease each year. And this obviously has a large impact on a country's economic viability. So now just to talk a little bit about what cardiac rehabilitation actually is. It's an established and integral model of care that's designed to mitigate the burden of disease. It's defined as the coordinated sum of interventions required to ensure the best.
We seem to have lost Tayla there. Sorry about that, guys. We are beset with technical issues. Let me try and contact Tayla and see what's going on. Sorry, everybody. Now it's an internet issue. We lost internet connectivity. So Tayla's just reconnecting, and then we'll recommence the talk. Welcome back, Tayla. I'm just going to give you presenting permission again. You're on mute at the moment.
I have no clue what's happening today.
It's one of those days.
I do think there is a problem with our Eduroam Wi-Fi, so I've just changed Wi-Fi for us. So
thank you, Savina. Thanks for your assistance and being here to sort it out. Tayla, I'm just going to make you presenter. There you go. You should be able to share your screen again. There we go. We can see you again.
Please tell me where I lost you.
We were on, I think, a previous slide. Let's just see.
The South African.
You just finished speaking about the burden of disease, and then we were talking about the economic impact. So we lost you where you said indirect costs, and then I dropped from there.
I'm so sorry. We seem to be having terrible Wi-Fi issues today. Costs with the direct hospitalization, medication, physician fees, and the indirect costs as productivity and work loss. So they for a report called A Race Against, which reports that at least 21 million future productive years are lost due to cardiovascular disease each year. And this obviously has a very large impact on a country's economic viability. So now just to talk a little bit about what cardiac rehabilitation actually is. It is an established and integral model of care that is designed to mitigate the burden of cardiovascular disease. So it's been defined as the coordinated sum of interventions required to ensure the best physical, psychological, and social conditions so that patients with chronic or post-acute cardiovascular disease may preserve or resume optimal functioning through improved health behaviors and slowed or reversed disease progression. So the services are typically multi-component, and they are delivered through an interdisciplinary and multifaceted approach. And the core components often differ between regions and countries, but typically will include an assessment of risk factors, nutritional guidance, weight management, blood pressure management, cholesterol management, diabetes or blood glucose management, smoking cessation, psychological management, physical activity guidance, and exercise training. And the ultimate aim of these multi-component programs is to stabilize, slow, or even reverse disease progression, as well as optimize functioning, reduce risk factors, foster healthy behaviors, and improve quality of life and reduce disability. So there's just a little picture to show the different components. So in terms of the role of exercise, we know that exercise and physical activity has multiple health benefits, and this has been very well established. But the College of Cardiology, and a class and beneficial, useful, and effective recommended in inclusion of exercise in.
Tayla, sorry to interrupt you. The signal is still quite poor, and your audio is cutting in and out. Can I suggest you turn off your camera? That might help, because I think the Wi-Fi bandwidth is somehow affected on EduRAM at the moment. Not sure if you're able to hear me.
And now can you hear me?
Yeah, if you can cut out, if you can turn off your camera, I think that's maybe eating a lot of the bandwidth.
Can you switch? Yeah, I'm switched.
There we go.
Joan, can you hear me?
Yes, now I can hear you clearly. Yeah, thank you.
I'm sorry, I've switched
one of those days.
Again. Yeah, it's terrible. I'm terribly sorry. Can I continue?
Yes, please do.
Okay. All right. So there's substantial research that the inclusion of exercise in cardiac rehab has a favorable effect on functional capacity, as well as hospital readmissions and mortality in coronary artery disease patients. And in one of the most recent systematic reviews on exercise-based cardiac rehab, it had very positive effects on quality of life, and it's generally considered to be a vital intervention that should remain central to rehabilitation and prevention of cardiovascular disease. So we've got very strong evidence to support the inclusion of exercise in a cardiac rehabilitation program, but there are still massive gaps worldwide in service delivery and implementation. So in 2014, it was estimated that cardiac rehab programs are not available in over 60% of countries worldwide. And where they do exist, there is an insufficient capacity to meet a continuously growing demand. So a massive discrepancy actually exists between the availability of these programs in high-income countries, so European region, and low and middle income countries such as Africa. So approximately 80% of our cardiovascular related deaths are occurring in low and middle income countries, but cardiac rehabilitation is only available in 23% of the LMICs, where majority of these deaths are occurring. So the existing cardiac rehabilitation programs are believed to have an insufficient capacity to meet the growing burden of cardiovascular disease in these countries. Across all low and middle income countries, it's believed that 14 million more cardiac rehabilitation slots are required to treat all ischemic heart disease cases annually, with more programs and more slots being required to treat other indications. So the availability of cardiac rehab programs is low relative to the growing burden of cardiovascular disease. And in addition to this, there are also several barriers that are preventing attendance to available programs. And two of the major barriers in low and middle income countries are a lack of resources and a lack of affordability as well. Is everyone still with me? I haven't lost anyone yet.
We're all here and we can hear you perfectly clearly. Thanks.
Okay, great. All right, so here's another from the same paper, the 2019 paper by Turka Dawi. You can see this is referring to the global presence of cardiac programs. And you can see that South Africa, again, we've got a relatively low program number per country compared to the very high burden that we saw on the previous map. So we know that South Africans are facing a rise in non-communicable diseases as a result of physical inactivity and an associated shift in both lifestyle and culture. And the South African population as a whole is considered to be insufficiently active, with approximately 49% of women and 43% of men meeting physical activity guidelines that are necessary to achieve health benefits. In 2000, approximately 3.3% of all deaths in South Africa were as a result of physical inactivity, and majority of these deaths were specifically related to ischemic heart disease. The high levels of morbidity and mortality associated with cardiovascular disease has major implications for our healthcare services, and it places an increasing strain on a public health system that is already struggling. So in 2019, our population estimate was approximately 58.8 million. And majority of these individuals are relying on public health services and public health clinics to access healthcare. So it's believed that the private sector only serves about 16% of the South African population, whereas the public sector is serving 84%. So these massive discrepancies between healthcare services in the public and private sectors is leading to the problem of inadequate healthcare for those in the public healthcare service system. And we know that public healthcare is typically characterized by numerous problems, including long waiting times, poor quality healthcare, poorly maintained infrastructure, inadequate resources, limited material resources, limited equipment, and limited supplies. So we need cost-effective primary and secondary prevention and management measures to slow down the growing cardiovascular disease epidemic, as well as relieve strain on our South African healthcare system. So currently in South Africa, we have only 23 cardiac rehabilitation programs. And of these 23 programs, none of them are in the public healthcare sector. They all exist in the private healthcare sector, making them unsustainable and unattainable for people that are using public healthcare. So of the 23 programs, two major barriers were reported, and that was a lack of patient referral, as well as a lack of financial resources. The yearly incidence of ischemic heart disease in South Africa is 108,000 people per year, but currently our national cardiac rehab capacity is 2,070 individuals. So there's a very massive discrepancy between the South African incidence rate and the capacity of our available programs. So to our knowledge, there are no known cardiac rehab programs within the public healthcare sector, and the need exists for more programs to assist in reducing readmissions, mortality, comorbidities, and improve quality of life throughout the country. Right, so this brings me on to my research, and I thought that I would speak just a little bit about Victoria Hospital first. So Vic Hospital, it's a level 1 district hospital. It's based in Wynberg, and it's run a cardiac rehabilitation clinic for a number of years, where the focus is on education and education sessions. So these sessions are informing patients about that are affected by a cardiac event about cardiovascular disease, its management and prevention. And the speakers include the head physician, occupational therapists, dietitians, and some of the UCT biokineticists as well. The program is unique to Vic Hospital, and it was designed and implemented by Dr. Nassif van der Skeef and Dr. Clint Cupido. So unfortunately, due to a lack of capacity, as well as the appropriate facility, there's no exercise component to this program. And so once they complete the education program, these patients are discharged and sent home. So the UCT Biokinetics program have been working with Vic Hospital for a few years now, and we've been trying to identify where biokineticists can contribute to public health care. And it was since identified that one of these areas that we can assist is through the addition of an exercise component to their existing cardiac rehab program. Right, so this brings me to my MPhil now. The purpose of this study was to investigate the feasibility of including an exercise component to the Vic Hospital cardiac rehab program by determining the recruitment potential for such a program. So it was a retrospective database feasibility study, and it was done using Victoria Hospital's VIMRI research database. So the sample consisted of data from all patients that were registered and logged onto the REDCap database system with a cardiovascular disease-related issue from the 1st of September 2020 to the 1st of December 2020. The individuals were screened according to the ACSM's contraindications for inpatient and outpatient rehabilitation to determine how many individuals would be eligible to participate in a supervised exercise program. And this program, the initial idea was to have it only under the supervision of a biokineticist because there was no other staff available at Vic Hospital to supervise the exercise component. So we excluded individuals that passed away due to their condition. And we also excluded any patients with complications such as cardiogenic shock, gastrointestinal bleeding, stroke, or renal failure because they were deemed as having disease or complications too severe to partake in exercise. So once we'd removed those patients, we then screened them according to the ACSM's criteria, which is there. So patients with one or more of the contraindications were excluded. And then what we did is we analyzed the remaining population in terms of demographic data such as age, sex, height, weight, waist circumference, and BMI. We looked at their admission and discharge dates, so the time that they spent in hospital. We looked at their admission diagnosis, what comorbidities they had, if they had any complications, what medications they were on, and any other healthcare marker that we thought was relevant. So a total of 225 patients were admitted in those 3 months from the 1st of September to the 1st of December. 16 passed away due to their condition, so we excluded them from the further data analysis. And then we screened the remaining 209 individuals according to our inclusion and exclusion criteria. So what we found is that 109 individuals, or 52.2%, were ineligible, and 100 individuals, so 47.8%, were considered eligible. So our initial hypothesis when we started with this research was that a high volume of patients would be eligible because we know that public hospitals admissions are typically high, they're overburdened, and we know that the burden of cardiovascular disease is quite substantial. So our hypothesis was correct. 100 people within the span of 3 months is definitely considered quite a high volume. But although we had high volumes of eligible patients, we also had a high volume of ineligible patients. So 52% were considered ineligible, and the split was almost equal. So it's quite clear that individuals being admitted to the hospital for cardiac-related events suffer from illness too severe to partake in an exercise program. And we can assume that the reason for this overburdening, the reason for this is due to the overburdening of public hospitals, because only those with severe cardiovascular disease are then admitted. We can also, sorry, hang on, I've lost my place. Additionally, this was obviously done during the COVID-19 lockdown period. So we can actually assume that this potentially also played a role. And again, only individuals with very severe or critical disease were being admitted to public hospitals. So within the original protocol for our exercise component, we only would have had the capacity to manage 2 groups of 6 participants every month, where each group would have 2 supervised exercise sessions per week, and the total number of participants could not exceed 12 per month. And the staff that we required for this was estimated to be 3 students or intern biokineticists for patient monitoring, 1 instructing intern biokineticist, and 1 supervising biokineticist per intake group. So based on the recruitment potential from the study, we can expect approximately 33 patients to be eligible every month. And this is nearly triple the expected intake of 12 patients per month. So it well exceeded the prospective resource and staff capacity for the program. So attendance rates are reported to vary across the globe, but most attendance rates for cardiac rehabilitation are considered suboptimal. There was a study done between 1986 and 1990, so a very long time ago, in Johannesburg, that said there was a completion rate of 50% for a single cardiac rehab center. But even if we estimate that our attendance rate is going to be 50%, we can still expect approximately 17 patients per cycle, and that still exceeds our capacity. So we've had to change the plan and pivot slightly. Because of the limited capacity, the limited resources, the lack of staff, and the lack of space at Vic Hospital, we've now proposed a joint public-private cardiac rehab initiative. And this is a collaboration between the UCT Biokinetics program, Cape Sports Medicine, and Victoria Hospital. And this collaboration provides us with an opportunity to use existing resources and staff at the Sports Science Institute that could not be provided by Vic Hospital alone. So my master's dissertation, we used very stringent criteria to determine eligibility because the initial idea was that the program would be run by biokineticists alone, without the supervision of a specialist physician. And this was because the only voluntary staff that we had available were the biokineticists. So what we saw with the recruitment study was that there were a number of individuals with very severe symptoms and disease that were not classified as eligible to partake in the exercise component. So the idea is that by collaborating with specialist physicians, we are also able to include some of these patients that previously would not have been eligible to exercise under biokinetic supervision alone. So this is the suggested structure for the new program. After the completion of the education arm of the cardiac rehabilitation program at Vic Hospital, select patients will be invited to complete a stress ECG test. The results of the stress ECG will then be analyzed by the attending physician, and those deemed safe to exercise will be referred on to the exercise arm of the program. Prior to entry into the exercise program, each patient will attend an extensive consultation with a sports and exercise medicine physician, during which a history of all comorbidities, lifestyle-related components, exercise limitations, and musculoskeletal limitations will be assessed. Following this, each patient will be prescribed specific exercise modalities and intensities based on their respective morbidities and limitations. And additional goals will be set in terms of risk factor modification, exercise capacity, and functional improvements to be made. We'll also do individual tests, and that would include an exercise capacity test, so a 6-minute walk test, a history of their risk factors, blood pressure, fasting glucose and lipograms, and whatnot. During the first week, they will be invited to attend a one-on-one exercise class, and this will be to familiarize the patient with the exercise program and to observe the response that they have to exercise very closely. And after this one-to-one session, they will then be invited to join the group exercise sessions. So during these group sessions, medical staff present will include 1 specialist physician and 1 biokineticist for each 6 patients. The biokineticist will then present specific exercises for each patient in the group. Intensity will be very closely monitored using telemetric heart rate monitors. We'll be measuring blood pressure before, during, and after exercise. We'll be monitoring RPE very closely, as well as additional measurements such as oxygen saturation or blood glucose where necessary. We've got full resuscitation equipment present, so we're very lucky here at the Sports Science Institute, and our patients will be watched over very, very closely. So the program will run for 12 weeks, and that's 24 sessions, so 2 sessions every week. And on the completion, we'll do a full reassessment and risk profiling. And patients who then meet the criteria for safe and independent exercise will be discharged to other programs at the Sports Science Institute or allowed to exercise independently. And those that are not deemed safe to do so will be invited to recomplete the program. So the ultimate goal of the program is for it to become sustainable, so that we're not relying on voluntary work and where our staff can be fairly remunerated for their time and efforts. So how we've chosen to do this is to use the same payment scheme that is used for public health services. So each patient will be allocated to a subsidy tier based on their household income. This will be either H0, H1, H2, or H3, and then they will pay the fee that is required based on that tier. And the idea behind the financial commitment is that it will also help hopefully encourage commitment and attendance to the program, because now patients have made a financial commitment. And here's just a little picture of what the patient fee assessment form looks like. And then on the left, you can see the actual rates, very, very low. So an outpatient consult with a specialist medical practitioner, so that would be our sports and exercise medicine physician, varies from 75 to 80 Rand. So it's very, very low, and hopefully won't be a problem for our patients to pay. All right, that is it. I'm terribly sorry for all of the technical glitches. Thank you for taking the time to listen to me regardless.
Thank you so much, Tayla, and thank you for that very in-depth overview of the global situation and an introduction to South Africa. It's a ripe area for not only implementing health interventions, but also from a research perspective, and that's something that really is important. And the reason why I say that is because in a European perspective, the health modeling, the cost analysis and of implementing cardiac rehab programs has actually been shown to be a net zero benefit, because the cost of the cardiac rehab programs seems to balance out in terms of the healthcare costs of admission of patients with cardiovascular disease. But what hasn't been modeled either globally or in South Africa is the overall cost in terms of the socioeconomic cost of patients who do have recurrent cardiovascular events and are readmitted, and the subsequent morbidity that they experience. So that's something that we should ideally investigate as part of the implementation of this program, and I hope that we can get that data in. But thanks very much for giving that introduction, and to everyone who's in the audience. We should be launching the program in the coming weeks once we get all the protocols up to speed and clarity on exactly what the little finer points are in terms of that. So I'm going to open the floor to any questions, and by all means, please pepper us with whatever you want to ask. No questions from anybody? Okay. While we wait for Steve, yes, go ahead.
Tayla, thanks for excellent presentation. It's very encouraging to see that extension into public sector. I've always been intrigued by something I read once, and I was looking for the reference now, that cardiac rehabilitation, if you apply evidence-based criteria, has been shown to be very effective at an individual level. But it has been shown to be ineffective at a population level. So, and part of it is the exclusion. So 50% are excluded, first of all. And then the tricky business of recruiting them into a program and keeping them in a program, which is a whole different science.
Yeah.
To, how do you make the heart function better? And it's always intrigued me, this difference between the evidence for individuals and the evidence for populations. And I think we're dealing with quite different interventions. Think of the challenges of recruiting patients in, having excluded half of them anyway because of the exclusion criteria. And then the 50% that are left, you're trying to make it possible for them to even start, and then having started, to keep them in the program. So at a population level, it doesn't work. It was the conclusion of this paper. I'm seeing if I can find it. And I'd be interested in your and others' comments on that.
I think potentially maybe one of the issues could be the lack of standardization of these programs as well. I mean, the components vary so much, and even the types of exercise that is done with these patients, the intensity of exercise, perhaps because it is so varied and it's very much case by case. Maybe that's why we see it so much more at an individual level versus a population level. But very interested to read that paper, actually.
I'll see if I can find it, yeah.
But Steve, just to also speak to that, I mean, I think the key is that at a patient level, but also in a group level. For instance, if we look at cardiac rehab data on patients who have cardiac failure, the readmission rates drop by over 50% in the group that undergoes cardiac rehabilitation versus those that don't. So even at a group level, the benefit in terms of readmission is very high, and obviously the improved quality of life as well. But what you point out is that, at a population level, there's not any significant impact on cardiovascular disease burden. And I think that relates partially also to the low, like you say, first of all, we're excluding 50% of people or whatever the exclusion criteria are, but just the small number of programs means that their impact isn't really felt at a global or a larger level. And so the modeling of cardiac rehab programs and the impact that they'll have and the cost benefit analysis is definitely a big factor. I think in a South African context, there's likely to be an even greater benefit because most of our patients are from lower socioeconomic status than the research that has been conducted in the US predominantly and in Europe. Most of them have greater comorbidity and a higher number of risk factors. And so there's potentially an even greater benefit to reducing those readmissions. And I mean, NARCIF's data from Victoria back in 2016, I mean, their coronary artery disease readmissions, so their acute coronary event readmission rate was over 56%. So, if you can reduce that, the other impact that we also have to model is what is the benefit to other patients? Because if we reduce the medical admissions by 20 or 30%, you open up beds to treat other patients as well. So there's so many factors that aren't being even investigated, and the impact could actually be, because now you're changing from in-hospital care to community-based care or effectively at-home care, and so there's even that socioeconomic benefit from that perspective. So lots and lots of data to be collected, and we need to see what the final analysis shows. But I have a strong conviction that there's going to be a net benefit in many ways that we haven't yet modeled, not just the direct patient benefit. There's a question from Nyla who's got her hand up. Go ahead.
Hi, thank you, Tayla. That was a very interesting talk. Just a disclaimer that I came to this talk because of the benefit that I saw with this program for my dad. So my dad was on the cardiac rehab program that was started with Wayne Derman and Tim Noakes. I think it was 1995. So he had a heart attack in 1995 and was on that. So this dates before the building of the sports science. And he was on the cardiac rehab program for 10 years. Right?
Wow.
And absolutely, at an individual level, he didn't have a relapse. He's really, like, I would say, a very good he's a positive, like a win for the program. But like underlying that, now reflecting back, why he maintained 3 times a week for 10 years. He's did aerobics, he even got into yoga at one point, but it was covered by the medical aid at the time. And as soon as the medical aid reduced the cover of cardiac rehab, he stopped going because he didn't want that cost 3 times a week out of pocket. So I think I just caught the last slide of where the assumption was that 70 to 80 Rand was a reasonable amount. I think it was per session to cover, which that's an assumption that needs to be tested, because it really depends on what that patient is able to cover. And then maybe I can't remember the slide, but have you factored in travel costs? Because in the public sector, people are using public transport, and then it's like, is it on your way to work? Is that an extra taxi or bus? Are they taking off work? Do they have the flexibility? Are they losing hours in their job also? So there's that cost factor as well.
Absolutely.
Yeah. So your program looks absolutely like it will work if they come twice a week for 12 weeks. But I think we just need to think of the before and after, and all those other like social determinants that could stop people from maintaining like a proper continuous way of coming to the program. Because even with my dad, that was private sector medical insurance covered, and basically as soon as the medical aid withdrew that cover, he was like, I'm okay now. I'm not going to add this to my bill every month. And yeah, there's that tension of just like what's going to make someone arrive on the day.
Absolutely.
Yeah.
Sorry, just to add, so the 75 Rand, that's just for the first consult with the sports and exercise medicine physician. For each group class, it ranges between 10 to 20 Rand. So it is cheaper, but again, you are very right. The economic climate at the moment in particular, we have to be very cognizant of this. Transport has been a big part of our discussions in the preparation for this, because public transport, we know, is firstly unreliable, and private transport not everyone has access to, and it's expensive. We have tried to make the classes, we've actually added 2 earlier classes to try and accommodate for people going to work. I think there's one is at midday and one will be nice and early. I can't remember the exact time offhand, to try and accommodate. But it's a very good point that you make. You need to factor all of these things in.
Yeah, if I can also just add to that. So, Naila, thank you. That's great to hear that your dad attended the initial program for 10 years. And in fact, that program still continues, which is one of the reasons why we can do this public-private partnership, because the reality is that the costs are high in terms of staffing and equipment and the facility. So the only way that we can make this work for the public sector is to do a public-private partnership where we do 2 things. One is the economies of scale, and the more people that we have, the more cost-effective it is for everybody. But in the private patients that are paying the normal rates, there's going to be some cross-subsidization. There's a heavily cross-subsidized activity. And then we're also able to meet some of the costs because of the fact that people like Tayla, myself, Caroline, and Jacqueline are involved together with other people whose time is already covered by their academic work and so forth. So definitely the costs of a cardiac rehab program are one of the barriers, and then the other costs that you mentioned, such as transport. And those are all the things that we need to look at when we look at the research in terms of modeling the overall cost benefit for cardiac rehab programs. But thanks so much for letting us know about your dad and the comments. Lee was the next person who had a question.
Thanks, Taylor. Thanks for a great talk. So for those of you who don't know, I'm currently running the cardiac rehab program at Sport Science now through Cape Sport Medicine. And I think, Steve, I just wanted, in answer to your question about the evidence for on a population scale. So my comment would be looking at like what evidence is available, because actually being in it and running the program, it is, as Jurin says, it's very intensive from a staff perspective, staffing, facilities, and equipment. So in our program, we have our patients have had excellent outcomes. They're dedicated, they continue, but it is on such a small scale because of the costs associated with it, so that if similar programs to this are compared across the board in your general, in the literature, I can't see how that would, it's not upscalable to a population level, which is going to show that it's not having an effect on a population level, simply because I'm not sure that this has been upscaled to a level where it's comparable. So I think the really good programs are really small, and that evidence, it's not that the evidence shows it's not comparable. I don't think the evidence is good enough, that we'd have good enough evidence to look at it. That's the first thing. And the second thing is my patients that are in the program, you know, if you look at them on a one-by-one basis, the impact on their individual lives and quality of life is just phenomenal. And happy for them, they're happy to discuss it. But, you know, it's also changing a question of opinion of, we've got referrals coming in from more and more cardiologists now, but we even have cardiologists who feel that he's not sure why his 85-year-old patient should be coming to cardiac rehab, because he should be sitting in his armchair having tea all day. And my answer to that is, our rehab allows him to sit in his chair, get up and go make his tea and come back, because actually that is his. So we, for the patients that are doing it, it makes such a big impact on their lives. But because it's so cost resource intensive, it is, you know, we have to, it has to be done on a small level. So that's just from a practical level. Thanks, Joan.
Thanks, Lee. Yeah, Tayla, if you don't mind, I mean, I can respond to that in terms of, Lee, the long-term goal is to broaden this out to a community level and have community health, community rehabilitation workers and community health workers being the coalface of these programs. And, you know, a big part of that is assessing screening methods and looking at adverse outcomes, acute medical events, and how we can prevent those at a community-based program level. So that's definitely something to look at in the future, and that will help in terms of the costs and the benefit of it.
Definitely.
The next person had a question was Nancy. Go ahead.
Okay, hi, sorry, it's Delva here sitting with Nancy.
Oh, Delva, yeah. Okay.
Tayla, thank you very much for that. I just want to ask if your team have considered and been in discussion with companies like Discovery to partner with?
That actually did come up in our discussion. I think the idea was to first roll it out and start running some research so that we could prove to them that the program was feasible, that it had a positive impact before getting them involved. But it did come up in discussion. Joan, I don't know if you want to also add.
Yeah, we had long discussions with Discovery a couple of years ago, and unfortunately, pessimistically, what happens is Discovery likes to have long discussions, meet and learn about all the ways that you're providing healthcare, and then they went on, and then we suddenly had no more correspondence with them, and it looked like they were wanting to implement something on their own. So unfortunately, we don't have great support from Discovery. Momentum used to pay for the majority of the cardiac rehab patients. They were very good. And for some reason, they at some point also decided not to refer as many patients for cardiac rehab. So, you know, the medical aids are an ongoing aspect in terms of, you know, getting them to, first of all, agree to pay for cardiac rehab and to support it and even proactively refer patients to cardiac rehab or ask their patients to come. And a big part of that is getting the data in to show that there's a net benefit for them, because when it comes to the nitty-gritty, the medical aids are interested in saving money and making money. So certainly that's part of the equation. But we have had discussions with Discovery as well, and it didn't actually lead to anything substantial or anything at this point in time.
Yeah, I'm just thinking that as your model grows and with that comes a wave of publicity and marketing, you may get better support.
Absolutely.
Hopefully. Yeah. Tasneem.
Thank you, Delva.
Thanks, Delva.
Yeah, thanks, Jeroen, and congratulations to Tayla and the team. I think it's very exciting. I just want to echo something that you said, Jeroen, about we're waiting for it to come out to community platforms. I think you guys are doing a sterling job in terms of developing the intellectual capital. And then the next phase, I would assume, is how do we translate that is to answer Steve's question around how do we massify this. I'm just looking at an interesting Cochrane review at the moment about comparing center-based cardiac rehab to home-based cardiac rehab. And they actually found very little difference statistically between the outcomes when they looked at fairly broad. I haven't looked at the actual study, I'm looking at the abstract. So it's quite interesting. Obviously, we don't want to rush into that process, because I think we need to establish the space for sports and exercise medicine within the broader public health space. I think that needs to be done very well. My question is, are you only looking at people's hearts? because I can assure you that if we start looking at lungs, there's a whole lot of work that needs to be done from a COPD perspective. We've got this huge burden of disease, maybe even bigger than the MI burden of disease at the moment, for people needing some type of pulmonary rehabilitation. And is that on the radar at some stage?
Absolutely, it's already on the radar strongly. Richard van Zyl-Smit and his colleagues at the in respiratory medicine actually are very keen to get their patients in, particularly their patients with severe COPD, pre and post transplant, lung transplants patients as well. And then they're working with Dale Ray also on patients who have obstructive sleep apnea and the long-term morbidity and mortality consequences of that. So we are engaged with them, and hopefully once we've got this up and running, we can then start to bring the respiratory patients in as well. And they certainly have a long backlog of patients that they want to refer and get into the program. So that's definitely on the cards.
Jeroen, can I interject here?
Go for it.
So also, yeah, just to respond to that, so Dale and I have actually completed a first master's project looking at the physical activity differences between people with OSA and matched. And so that was, and we also had a student put together a framework. And so we were impeded by COVID, but those first steps have been taken to hopefully implement that within the respiratory OSA clinics.
Thanks, Cara. Steve, you had another question.
Yeah, I just wanted to respond to Lee to say, certainly not disputing that the patients in your program benefit. My point was, so if you get in, this is not the article I was thinking about, but it's pointing in that direction. Why do so few people with heart failure receive cardiac rehab? And there in the abstract is what I've highlighted. A more holistic approach is proposed as an alternative to the predominant focus on exercise, emphasizing the important role of education and psychosocial support. Plus all the barriers of geography or finance or whatever it is. So I'm saying that there's a different set of skills necessary to look at a population, and our biomedical training focuses us on the individual. In bridging that gap between the individual and the collective, we actually need a whole lot of non-medical people. We need communications people and marketers and social scientists and people who help us to navigate that space, because we're not good at it. We're not good at it. We know what works. We know what works, but it's not getting out there. And so, yeah.
Sorry, I meant 100% agree with that. I was muted.
Absolutely. Okay. I think that's bringing us, actually, we've just run over time, so that brings us to the end of the meeting, although we lost a few minutes with some technical issues. I don't see any more questions, so I'm going to then say let's wrap things up. I see there's a comment in the chat group. The case study of Mr. Conrad, he was a smoker, 40 cigarettes a day, and the heart attack he had at 45 years of age saved his life. The smoke cessation program was life-altering. Yeah, absolutely. I mean, the educational component is obviously focused on the lifestyle-related factors that contribute and perpetuate the disease process. And so, and smoking cessation is one of those. So, a good point that's made in the chat group as well. So thank you everybody for attending, and Tayla, thank you for your talk, and I look forward to getting this program on the road, and hopefully we'll generate lots of data that we can present at future seminars that will start to speak to all these various different aspects that we've discussed following the talk. But thank you everybody, and wishing you all a great day further.
Thank you so much.
Thanks, Jeroen.
Thank you.
Thanks very much. Cheers.